immediately like to go on with Thomas Bachelot with his presentation, and then we'll discuss all three presentations at one time. Please, Thomas.
Okay, thank you. I'd like to thank the organizer of this symposium to give me the opportunity to speak about combining targeted therapy in ER-positive metastatic breast cancer, and specifically the addition of mTOR inhibitors. So there are my disclosures. Okay. So you all know metastatic breast cancer is metastatic breast cancer from ER-positive breast cancer is a hormone-sensitive disease. And when you give a hormone therapy like letrozole in first-line metastatic setting, you have very good response rates and a time to progression of 9 months. Nevertheless, you have 30% you have 30% of those patients that will not respond at all to the treatment and are considered to be a primary hormone resistant. The other one will respond and then progress later on and should be considered as secondary hormone resistant. At one point, all our metastatic patients with ER-positive disease will be hormone resistant. So there have been a lot of in vitro studies to explore the biology behind the hormone resistance. And specifically, it's been shown to be a crosstalk between signal transduction pathway and ER signaling. In fact, the estrogen receptor, even when it's not linked to estrogen, can bind to growth factor receptors at the membrane and activate cell proliferation through the PI3 kinase AKT mTOR pathway or the RAF MAP kinase pathway. This is the so-called non-genomic effect of the estrogen receptor. So with this in mind, it's a clinical trial have been designed to associate inhibitors of the mTOR receptor, of the mTOR pathway, or inhibitors of the growth factor receptor EGFR1 or HER2 in association with aromatase inhibitors. I will first speak of the growth factor receptor inhibitor in association with hormone therapy. Several studies have been published. The most important was published by Stephen Johnson in GCO in 2009. This is a very important study that included 1,200 patients and compared letrozole to letrozole and lapatinib. Lapatinib is a nice thing to do there because it's both an inhibitor of HER2 and HER1. Those patients were stratified for the expression of HER2. The first analysis was for the HER2 positive population. In this population, there was a strong benefit of adding lapatinib to letrozole with a progression-free survival that was increased from 3 months to 8 months. This was significant at 0.19 and confirmed the previous tandem study that had compared anastrozole to trastuzumab and anastrozole in this same population. And this tandem study have shown the same result of a significant increase of time to progression. The story for the HER2 negative population is not that clear. Obviously, this study is negative for this population as a whole, and this is in line with other studies that have been done with this population with HER1 inhibitor in association with anti-estrogen. Now, when you look at subgroup analysis, you can separate the population with very strong hormone sensitivity, that is on the left panel. Those patients were first-line metastatic, in the first-line metastatic setting. Some of them did not receive any tamoxifen in the adjuvant setting. Some other had received tamoxifen but progressed very late, more than 6 months after discontinuation. So those patients very hormone sensitive did not benefit from HER1 inhibition. On the other hand, patients that had progressed during tamoxifen in the adjuvant setting, so they could be considered as primary hormone resistant, seems to have some benefit from the association, with a trend of increasing median progression-free survival from 3 months to 8 months. So this was not significant due to the small population, but obviously there's something to study here. So as a conclusion, for growth factor inhibitor receptor in association with anti-estrogen treatment, in postmenopausal patients with HER2-positive metastatic breast cancer, it has been shown in 2 studies that the addition of an HER2 inhibition to hormone therapy is beneficial. For patients with HER2-negative metastatic breast cancer, for the moment, the results are negative. It has not been shown that the inhibition of HER1 does anything more than letrozole alone in this population. But there may be some subpopulation with primary hormone-resistant patients that may benefit from this treatment. And obviously, more studies are needed in those selected population. So we'll move on mTOR inhibitors. So as I told you, there is a strong preclinical in vitro data that support the activation of PI3 kinase AKT mTOR pathway for secondary hormone resistance. More specifically, on the left panel, here you have the so-called long-term estrogen-depleted cells. Those are cells that are spontaneously hormone-sensitive, like MCF7, that have been cultured for a long time in hormone without estrogen. At one point, those cells are able to grow in those estrogen-depleted medium, and we can have an activation, we can see an activation of the PI3 kinase pathway. As you can see, you have an increase in phospho-S6 kinase and the phospho-4E binding proteins that are the late effector of the pathway. When you treat those cells both with anti-estrogen and mTOR inhibitor, like RAD-001 or everolimus, you have a synergistic drug interaction. I will mostly speak of everolimus for these talks. Everolimus, or RAD-001, is an oral and potent inhibitor of mTOR. It has recently been approved for renal cell carcinoma. It has shown very promising activity on in vitro model of hormone resistance, as I've shown you. It has promising activity in early clinical trial, most particularly. In early clinical trial, it was given to patients who had progressed under letrozole in association with letrozole, and this was shown in some patients to be able to reverse their hormone resistance. More recently, it has been shown to increase neoadjuvant letrozole anti-tumor activity. This was a study published by Jose Baselga in the JCO in 2009. 260 and 70 patients were randomized between letrozole everolimus and letrozole alone, given 16 weeks before surgery, with multiple tumor biopsy for pharmacodynamic evaluation. It was shown that the addition of everolimus to letrozole increased response rates by ultrasound from 47% to 58%. There was a reduction in the expression of Ki67, more frequently in everolimus-treated patients, 57%, than in the control patients. You had this very nice pharmacodynamic study that was associated with this neoadjuvant study that could show that everolimus indeed inhibited the PI3 kinase AKT mTOR pathway in vivo in the tumor of those patients, as shown on the right by the decrease of phospho-S6 kinase in the tumor sample. So let's move to metastatic breast cancer. There is a few studies that have been done, few randomized studies that have been done in metastatic breast cancer patients with mTOR inhibitors. Actually, one previous phase 3 study was published in the San Antonio meeting in 2006 by Cho and al. And used temsirolimus, that is another mTOR inhibitor, in association with letrozole for first-line metastatic breast cancer patients. So as you can see here, this study was negative. The median progression-free survival was 9.2 months in both arms. There is no difference. One hypothesis for this negative result may be the fact that most of those patients, at least 70%, are in fact hormone sensitive when included in the study. So if they are already hormone sensitive, it's possible that giving an mTOR inhibitor on top of that doesn't add much. So we made the supposition when we designed the TAMRAD trial that selection of patients pretreated with aromatase inhibitor may be a means to enrich the study population with patients whose tumors are indeed driven by an activation of the PI3 kinase AKT mTOR pathway. So we designed the TAMRAD protocol with the Gineco team, that is a collaborative group, a French collaborative group, as a small proof of concept phase 2 randomized trial that compared tamoxifen 20 milligram daily to tamoxifen at the same dose plus everolimus at the recommended dose of 10 milligram daily. The patient that was included in the study should have had received aromatase inhibitor either in the adjuvant or metastatic setting. We made a stratification between primary and secondary hormone resistance, as this could be important for prognosis. We defined primary hormone resistance as patients who relapsed during adjuvant aromatase inhibitor treatment or very rapidly after initiation of aromatase inhibitor treatment in the metastatic setting. We defined secondary hormone resistance as patients who had a late relapse after completion of aromatase inhibitor in the adjuvant setting, or patients that had a response at least of 6 months in the metastatic setting. No crossover was planned in this study. The key inclusion criteria included menopausal condition, hormone receptor positive, HER2 negative. They could or could have not measurable disease, and they should have been treated with an aromatase inhibitor. They may have received tamoxifen in the adjuvant setting, providing they had relapse more than 1 year after stopping it, and they may have received chemotherapy either in the adjuvant or metastatic setting. The primary endpoint was clinical benefit rates at 6 months, defined by complete remission, partial remission, or stable disease at 6 months. The secondary endpoint included time to progression, overall survival, and toxicity. The statistical design was a classical Simon two-stage minimax design with a power of 90%. We wanted to be able to show a 20% benefits in clinical benefits rates in the experimental arm. And clinical benefits rates of up to 50% have been described with tamoxifen in this population. So we needed 53 evaluable patients in both arms. So with this design, there is no direct comparison between arms is expected. The results of the control arm is only here to give a degree of reassurance that the results of the experimental arm are valid. As a consequence, all the p-values that are given should be considered as exploratory. We include 111 patients between March 2008 and May 2009. The analysis that was presented at the San Antonio meeting in December was done in October 2010 with a median follow-up of 22 months. Most of those patients had disease progression in the metastatic setting for a long time, with a median duration of metastatic before inclusion of 14 months. 25% had bone-only disease. Most of them had received aromatase inhibitor in the metastatic setting. Finally, half of them were considered as primary hormone resistant, and the other half as secondary hormone resistant. Here is the result of the primary endpoint. The clinical benefit rates in the tamoxifen arm was 42%, and in the tamoxifen plus everolimus arm, it was 61.1%. We had those nice results in time to progression. Time to progression was increased from 4.5 months in the tamoxifen arm to 8.6 months in the tamoxifen plus everolimus arm, with an hazard ratio of 0.53 and 95% confidence interval of 0.35 to 0.81. Overall survival was increased. There was at least 3 times more deaths in the tamoxifen arm than in the tamoxifen plus RAD arm, with an hazard ratio of 0.32 and 95% confidence interval of 0.15 to 0.68. We had toxicities. Everolimus is known to give fatigue, stomatitis, rash, anorexia, diarrhea, and indeed, that's what experienced the patients of the experimental arms. Due to those toxicities, the reduction in everolimus had to be done in 28% of the patients of the experimental arm. On the other hand, the level of treatment discontinuation due to toxicity were low and equivalent in both arms. We made a subgroup analysis, and we could not show any difference in benefits for patients with or without visceral metastasis, for patients who had or had not received previously adjuvant tamoxifen, or who had not previously received metastatic chemotherapy. But with regard to hormone resistance, primary or secondary, we had an interesting result. It seems that everolimus was most likely efficient for patients who had secondary hormone resistance. This is shown here. In the top panel, you can see that patient with primary hormone resistance does not seem to have a lot of benefits from the addition of RAD01. On the other hand, patients with secondary hormone resistance, the down panel, seem to be the one, or maybe the one, because it's a subgroup analysis of a small trial, but that's quite interesting anyway. So maybe the one that benefits the most from this combination. So in summary, this is a randomized phase 2 trial of everolimus and tamoxifen for aromatase inhibitor pretreated patients. We could show that we had an increase in clinical benefit rates from 42 to 61%. Time to progression and survival were increased, toxicity was manageable, and clinical benefits may favor patients with secondary hormone resistance. There was another phase 2 trial that was published in the San Antonio meeting last year that was only on 11 patients, but what is interesting, it was an association of fulvestrant and everolimus. And on those 11 patients, the results are quite similar to the one we have published in the TAMRAD trial with a median time to progression of 86 months. More interestingly, the Bolero-2 study, this is a phase 3 study that is promoted by Novartis, have included 705 patients and was close to the inclusion late 2010. This study has exactly the same inclusion criteria as the TAMRAD study, that all patients that have been exposed to aromatase inhibitors before inclusions, and hopefully we should have the first results during this year. So it may confirm our results. So in conclusion, preclinical and clinical evidence suggests that EGF, HER2, and mTOR pathway contributes to endocrine therapy resistance. Now it has been clearly shown that for HER2 positive patients, aromatase inhibitor plus HER2 inhibitors are better than aromatase inhibitor alone. The results are not that evident for HER1 inhibitors. And we have just shown in this small phase 2 trial, the TAMRAD trial, that the addition of everolimus to second-line hormone therapy in the metastatic setting may be beneficial. Obviously, we have to wait for the results of the Bolero-2 study to know exactly what's happened there. Thank you.
Thank you very much, Thomas. Please join us. Are there any questions from the floor? Please use the microphones. They're in the aisle over here and there. Any questions? If there's no question, maybe I'll start. Thomas, what do you think of Bolero-2? Do you expect the same results with the use of exemestane compared to your study?
Yeah, that's a very good question, but a tough one too. We expect the same results, but it's not impossible that the tamoxifen by itself tamoxifen and everolimus may not have the same interaction that exemestane and everolimus, because exemestane doesn't act at the cell level, it acts for the synthesis of estrogen. Okay. So you keep the same estrogen medium, and then you add everolimus. So it may be different, so we don't know. Okay. Obviously, if the results are negative, we will have to ask the question.
Okay. Question over there, microphone, please.
These very convincing arguments in favor of zoledronic acid indication had a contra-argument in the hands of the insurance system. and they argue that the number needed to treat patients in order to avoid a skeletal event is 200 something, 200. So I feel it is better to put accent on the anti-tumoral effect. The distant metastasis will be less. So not the argument of 1% of skeletal event less, but the argument of improving the overall survival, having less distant metastasis.
If I may answer, I agree with you, but there are different environments. In some countries, you can give it for bone health, and in some countries, you can give it for adjuvant. So you have to decide upon the options in your countries rather, and I agree totally with you.
In
Comments?
Romania, the endocrinologist can give Aclasta free of money for bone health, and the oncologist cannot prescribe free of money for these indications.
Another good opportunity. It's always good to work together as oncology and endocrinology. I believe you totally. A question over there, please.
Yeah. This is from India.
Please.
This is for you, Dr. Hadji. Both the Austrian trial, Azure, and all these OFAS trials have given IV zoledronic acid for prevention, for benefit in oncology, cancer recurrences, and in preventing the osteoporosis. Is there any data to say oral bisphosphonates, like the like the Aclasta and the Risofos, does that work as well as the IV zoledronic acid?
With regard to disease-free survival, there's no data. We've looked into the data of Aclasta, we've looked into the data of risedronate and alendronate, and although there's huge studies with 6,000, 7,000, 8,000 patients, there was no benefit with regard to to breast cancer incidence or disease recurrence. So we have no data whatsoever today available. But maybe the sample size of 8,000 in a randomized controlled trial is too small. Maybe we need 20,000 in this setting to prove such an effect, and we don't have these data.
I have another question for Dr. Blackwell, and that is that you said to prevent osteopenia or osteoporosis for adjuvant setting, zoledronic acid, 1/5 of the patients will develop osteopenia if given ovarian suppression plus tamoxifen or AIs. Why not wait? 4/5 will not develop it. So why should we not wait and do yearly, bone studies and then give it to those 1/5 who develop it?
Yeah, so just to repeat the question, it's in reference to one of the slides I showed towards the end of my talk. Right. That was directly from the ZFAST and ZOFAST data. So those were postmenopausal women who were all receiving letrozole therapy. And the question in those studies was upfront use of zoledronic acid versus delayed once you saw documented bone loss. Our job in oncology is, unfortunately, we don't have a one-to-one correlation of picking the exact patients that benefit from the therapies we employ. So for instance, we treat a lot of women with endocrine therapy and chemotherapy and help a small percentage of women. That's the case. We'll give 4 cycles of AC chemotherapy to prevent recurrence in 5 out of 100 women. So we're used to treating a lot of women to prevent a reduction in breast cancer. I understand osteoporosis is very different than breast cancer recurrence. Right. But until we have an exact predictive marker, and to date we don't, as to who is deriving benefit from upfront bisphosphonates, that in some ways forces us to treat everyone, knowing that the incidence within the first year is 1 out of 5 women will derive osteoporosis. And until we have better predictive markers, the toxicity of these drugs, in my mind, ignore the cost for a second. The price to the patient, the toxicity of twice-a-year zoledronic acid, with the exception of fevers, is minimal. the price of having to restore bone health once osteoporosis is developed requires a fair amount of effort both on the patient and medical intervention. So in my mind, preventing that 1 out of 5 women becoming osteoporotic is worth the small toxicity profile of the oral bisphosphonates. And I agree with Dr. Haji, the cost is something we can't ignore, but the data really suggests that there's an anti-cancer effect and a direct bone health effect by employing these up front as opposed to waiting.
Please.
From Taiwan, I have one question to Dr. Blackwell. You present the first case of premenopausal, 40 years old, and hormone receptor positive. After the chemotherapy, just talk about the ovarian separation. I will ask your opinion about how long would you prescribe for the ovarian separation duration, and beside, would you add on tamoxifen or aromatase inhibitor for this patient, and how long?
Sure, you notice I didn't answer that in the quiz section. It's an individual choice as to whether a patient elects to have permanent ovarian suppression or not. Typically in my practice, a 40-year-old, I will strongly encourage them to have an LHRH agonist for a period of a few months before pursuing permanent ovarian removal. And that allows them an opportunity to really understand what menopausal symptoms are and how it's going to affect the quality of their life. I recommend that based on ABCSG 12, I recommend a minimum of 3 years of ovarian suppression. Although many other studies have looked at 2 years versus 5 years, there's no definitive time point for the use of ovarian suppression, and that's not really that bias is not accounted for in the Lancet Oncology overview where I showed you those forest plots. So in my practice, I recommend a minimum of 3 years. And I usually allow for an LHRH agonist trial period of close to 6 months. And then I usually approach women at that follow-up visit and discuss how it's affected their quality of life and whether or not they want to pursue permanent ovarian removal. It's amazing to me, you can't really predict patient preference. And so that's why I tend to allow for the course of LHRH agonist. And then many women elect to have a laparoscopic oophorectomy. 40 is hard because that is 10 years from the time of a natural menopause. And so that's where I really tend to not push to have ovaries removed. 47, 48 is not hard in my practice because really I think those 2 to 3 years after the diagnosis is the critical time for extreme estrogen deprivation. Women will be facing menopause anyway, and in women who have node-positive breast cancer, I showed you a significant disease-free survival benefit for the use of an AI over tamoxifen. And so in women who are older than 45, I frequently will recommend ovarian removal such that I can, with my whole heart, put them on an aromatase inhibitor in order to give them that early benefit in terms of distant metastases and disease-free survival.
Okay, we got one short question and one short answer. Please.
This is regarding use of the AIs and the tamoxifen in Big 98. And having got the MA17 and knowing the ER positive patients relapse over a long period of time, should we be using alternatively AIs and tamoxifen for 10 years?
I assume that's addressed to me. I believe that the risk for recurrence of ER-positive breast cancer extends a patient's lifetime. 50% of all estrogen receptor-positive recurrences occur after the 5th year. And so your question is an excellent one because we don't know the ideal duration given the increased use of upfront aromatase inhibitors. In my practice, in the absence of toxicity and in the absence of a clinical trial, I will continue aromatase. If someone started on aromatase inhibitor up front, if I get to the 5-year point, which many of my women have, I've continued the aromatase inhibitor because we have no data about aromatase inhibitor followed by tamoxifen at that 5th year.
For women who make it through the first 2 years on aromatase inhibitor, if they are suffering any toxicities, primarily arthralgia or excessive bone loss, let's say we didn't use an upfront bisphosphonate, the data from Big 198, and I didn't have time to go through it with much detail, really suggests that switching to tamoxifen after the second year really does not make a significant impact on disease-free survival. And so I push very hard to keep my women on the aromatase inhibitor for the first 2 years, recognizing that after that time point, if they are suffering from any excessive toxicities, I am very quick to switch them to tamoxifen. But that's more a switch for symptom management than it is a breast cancer recurrence prevention strategy. And until we have the results of studies such as B42, MA17R, right now, if they're doing well on a therapy without evidence of recurrence, I'm recommending at least 10 years of endocrine therapy.
Thank you. So I'd like to close by thanking you for your big interest in this symposium, Novartis for giving us the opportunity to discuss it, North Star for the excellent support we had in the past days. Please don't forget the evaluation form and the keypads, and I wish that we will all have a very exciting meeting here in St. Gallen. Thank you.